Thank you. Good afternoon, everyone, and especially Dr. Stephen for accepting our invitation to the HemoAlex. HemoAlex is one of the leading educational programs in Egypt, and we were unable to do the yearly event, which was the gathering of all hematologists and hemato-oncologists in Egypt. And we miss the perfect weather of Alexandria, and we miss Professor Ashraf Ammanal hospitality. However, we're going to cope as much as we can with this webinar, and we have the pleasure to have Professor Stephen Couture. He is from Stanford University, a very famous, of course, and well-known university, and he's going to enlighten us on chemotherapy-free for frontline therapy in this age and the age beyond, hopefully. Go ahead, Professor Stephen, please.
Well, thank you for inviting me to join you. I'm sorry I can't be there in person, but we've all been doing the Zoom meetings these days, so hopefully this will work out for you. So yes, I want to talk about really some of the newer advances in CLL. Of course, we've transformed how we manage this disease in recent years. And my title is a bit provocative, I'd say. Chemotherapy-free frontline therapy comes of age, and hopefully at the end of the presentation, you'll believe that this is true. So just a little bit of background. I'm sure you're quite familiar with this, but just to set the stage, of course, CLL is the most common adult leukemia, and when we talk to our patients, we explain, of course, that it's a cancer of the blood and the bone marrow, and specifically of the lymphocytes. It often has an indolent course. Of course, most patients present asymptomatic, and it's found incidentally, but others, either at presentation or eventually, do get adenopathy or cytopenias associated with the bone marrow involvement. There is some inherited predisposition, but of course, this is not a disease where we typically think of screening first-degree relatives. Now, the typical patient is 70 years old at diagnosis, and as I mentioned, without symptoms. So that's something I think we often overlook, especially in the context of clinical trials, because at least historically, most trials for CLL, when you look at the median age of the patients, it's usually less than 70 years old. There have been some more recent trials that deal specifically with older patients, so those have been very helpful because, after all, that's the average patient that you see in practice. Very straightforward to diagnose, as you know, peripheral blood flow cytometry, with the appropriate results and the right clinical setting is generally sufficient. And we have our staging systems, the RISE system or the Binet system, which are nice to frame a discussion with a patient. They really correlate with the extent of the disease, and they can help predict the clinical course, but they tend to lump rather than split patients into smaller groups, and we have better predictors of a disease course and outcome that add to what our staging systems give us. So, of course, one of these is FISH. So looking at specific chromosomal abnormalities, and this landmark study, now 20 years old, did a comprehensive study of CLL patients with many different FISH probes, and the results can sort of be summarized right here. There's really four abnormalities that are most important. The 13q deletion, where microRNA is located, is the most common. We see that in about half of patients at diagnosis, followed by 11q with the ATM gene, and then trisomy 12, and finally the 17p deletion, where the p53 tumor suppressor gene is located. Unfortunately, we only see that in less than 10% of patients at time of diagnosis. So we have a hierarchy, if you will, ranging from 17p all the way to 13q, and these can predict or be prognostic of, for example, time to progression. So an asymptomatic patient at diagnosis this gives us additional information beyond the clinical stage as to when a patient might require initial therapy. The second feature we have, of course, is the immunoglobulin heavy chain variable region mutation status. When B cells traffic through the germinal center, they get exposed to antigen, and the immunoglobulin genes undergo somatic hypermutation. We're left with memory B cells in some cases, and of course, we have clonal deletion that happens in the germinal center. So fundamentally, a patient will have either a hypermutated phenotype, so-called mutated CLL, or unmutated, where this process hasn't occurred. And that, as I'll remind you, does not change over time, whereas chromosome abnormalities might. So, for example, one can acquire a 17p deletion later in a disease course. So those are our two most important features that we can use for prognostic reasons, and in some cases also they might be predictive. So let's start with a case, and we'll use this to sort of frame treatment and treatment choices. So this is a 55-year-old man who was treated for an upper respiratory tract infection, fortunately not a COVID infection, and he was noted to have a peripheral blood lymphocytosis. So follow-up several months later after he had recovered still showed the persistence of this lymphocytosis. His other blood counts were normal. He has chronic obstructive pulmonary disease. He's a current smoker, and also he's overweight and has obstructive sleep apnea. But his performance status is quite good, and he works full-time. So his physician sent a flow cytometry on the peripheral blood, and not surprisingly, it showed the classic phenotype of CLL, monoclonal B cells, as implied by light chain restriction. The cells were CD19 positive, so they were B cells. They had other B cell markers, CD20, it's characteristically dim in CLL, and CD23, an early B cell marker. And then the hallmark, of course, is co-expression of a T cell marker, CD5, on this monoclonal B cell population. So this patient also had some shoddy lymphadenopathy noted in his neck, but no other physical findings, no splenomegaly. So diagnosis, very straightforward, asymptomatic CLL, and he was appropriately observed rather than treated. He really did not have an indication from treatment, and we know from historical clinical trials, actually, that early treatment of a patient like this does not change the natural history of the disease. So the so-called watch and wait, or watch and worry, as our patients call it, really became the standard with CLL. That's an approach that continues to this day. Now, the caveat, of course, is that those therapies in those clinical trials weren't particularly effective. And certainly with our newer therapies, which are dramatically more effective, this is an issue that is getting renewed attention. One trial, a so-called early intervention trial in asymptomatic patients, has been completed in Germany. We've had some preliminary results. That was with ibrutinib. And in North America, we're planning a trial as well. So 2 years later, he comes back to the office complaining of progressive fatigue. He has night sweats and some progression of his lymphadenopathy. And so he's wondering about treatment. So he has a further evaluation. His FISH showed a deletion 13q, and his IGHV was mutated. So remember, that's a favorable profile. Yet here we are 2 years later, and he has symptoms. So that's somewhat surprising. These patients with this type of profile usually go much longer than this before disease progression is noted. So his physical exam now, he's got 2 centimeter nodes in his neck and under his arms. No hepatosplenomegaly, so not bulky adenopathy, but his white count has risen. Specifically, his lymphocyte count has risen, and he's very anemic. Platelet count has fallen as well. Now, just as an aside, of course, the one thing you want to make sure of in this situation is that you're not dealing with an autoimmune hemolytic anemia as the reason for the severe anemia. You really want to make sure that this is really related to progression of his disease. I've also had patients perhaps present something like this who were iron deficient, and simply iron supplementation showed that their anemia wasn't as severe as first noted, or certainly wasn't directly, the severity wasn't directly related to their CLL. But in this case, it turns out that it was, and so he's clearly had progression of his disease. He's more symptomatic, and although he doesn't have bulky adenopathy, his significant anemia is a reason to treat. So when you're faced with this situation, I think one thing we have to always keep in mind is what your treatment goal is for an individual patient. When we're making decisions about treatment, of course, this is implicit, but sometimes I think it helps to really focus on this and say, you know, what do I want to accomplish in this person? And of course, that may be very different for someone like this who's quite young for this disease, as opposed to somebody who's say 80 years old. What's the ideal treatment regimen? Of course, that's what we'll be talking about. And then we can also look at this case a little bit differently and ask whether the management strategy would be different if this patient had an unmutated IGHV, or perhaps if he was one of those unusual patients who did have the 17p deletion. That wouldn't have been all that surprising, given that he progressed quite soon after his diagnosis, within 2 years. So that would be a more typical presentation of somebody with a 17p deletion rather than a 13q. Now, yeah, I have to acknowledge anytime I'm speaking, particularly outside the U.S., that one has to deal with reality. So it's nice to talk about all the different therapies, and we'll talk a bit about combinations of therapies. But I do realize that there's limitations. There's limitations in your practice that perhaps I may not have in my practice. First is whether you have the mutation testing readily available. My understanding is that you do, or you shortly will. So that could be helpful. Most places do have fish testing that's available and covered by health insurance. I believe at present in Egypt, you have ibrutinib frontline only for deletion 17p. And of course, I'm going to be speaking much more broadly about that. You use FC or FCR for young patients. I don't, for example. And chlorambucil with or without rituximab in older patients. Bendamustine, single agent rituximab, how about chlorambucil plus obinutuzumab? And then finally, of course, we have other novel agents, a second generation BTK inhibitor, acalabrutinib, and then our BCL2 inhibitor, venetoclax. So again, I will discuss really the results of trials and where we are currently in treating and managing this disease, but I do understand that you may have current limitations in how you can approach a patient. So previously untreated, and just a word about chemoimmunotherapy. So of course, you're quite familiar with the FCR regimen. It really became the gold standard of chemoimmunotherapy. I think the other dominant regimen, of course, was bendamustine and rituximab, and certainly in the U.S., BR was quite a favored regimen for older patients. But FCR, we have some very long-term experience with, was developed, of course, at MD Anderson Cancer Center by Dr. Keating, and the graph here on the right shows the long-term follow-up from their original trial. You can see the x-axis goes out to 16 years there, with a median follow-up in excess of a decade. And on the left is the CLL-8 trial from the German CLL study group. That was the FCR versus FR randomized trial. The follow-up isn't as long, but again, two high-quality studies, long-term follow-up. So when one looks at either of these studies, you can split patients into mutated versus unmutated. So the MD Anderson data, the IGHV mutated patients are the green and the red curves. So those are the most favorable versus the unmutated. You see the same difference in the German study. When one looks at the FCR regimens, the mutated is green, the unmutated is blue. Now, however, when one looks at that green curve in the MD Anderson data, you see the plateau. And when you hear people talk about this regimen and say that we're curing some patients with CLL with FCR, that's what they're referring to. That's limited to the mutated patients. But I will also point out something that isn't often discussed, and that is that benefit is primarily in those who have MRD undetectable disease after treatment. That's the green curve. When you look at the mutated patients who still have minimal residual disease post-treatment, that's the red curve. And that falls down closer to the unmutated patients. So the patients who really seem to have the benefit are those who are mutated and who have MRD undetectable disease after treatment. Of course, one doesn't know if you're going to achieve MRD negativity with FCR. And in this report, it was about 50% of the mutated patients. So one has to be a bit cautious when talking about so-called functional cure with FCR, because it's not a guarantee even if a patient is mutated. But this is an example of where the IGHV mutation status is predictive, not just prognostic. So it's predictive of response to chemoimmunotherapy. That's been very well established, not only in these studies, but in others. What about now turning to our novel drugs? And we'll start, of course, with BTK inhibition. So here's the obligate signaling pathway diagram. You can see the B cell receptor, which homodimerizes. It's a transmembrane receptor. The proximal pathway involves proteins such as LIN and SYK, and there have been SYK inhibitors, for example, developed and used in CLL. Then that continues down the PI3 kinase pathway, and you can see BTK. So these signaling pathways really regulate a number of very important cellular processes, such as proliferation. They involve survival signals, control of apoptosis, maturation, and cell migration and homing. And they are abnormally activated in CLL. And so the simple hypothesis early on is that perhaps by interrupting some of these key pathways, we can take away the proliferative advantage that the cells have, and also perhaps allow the return of normal apoptosis, so these long-lived cells can die their natural death. The first drug, of course, was ibrutinib. And at Stanford, we were involved in the first in man study. So I remember back in those days, it was quite remarkable to see this drug in a phase 1 study, to see dramatic efficacy among a variety of indolent B-cell disorders in very, very, very heavily pretreated patients. So it wasn't long after that first phase 1 study where safety and efficacy was demonstrated that the very next study was done. And that was a study done in heavily pretreated patients with CLL. These are patients that I'll never see again. I'll never see that extent of disease, that bulk of disease. Patients who had 12 prior regimens. I don't even know if I could list 12 regimens these days for CLL. So it was a very, very high-risk population. And we initially saw such efficacy that we opened a cohort of previously untreated patients in that very first study. So we eventually treated 31 patients over the age of 65, so typical CLL patients, who met standard criteria for treatment. So we have some very early experience using ibrutinib for frontline therapy. And here's the long-term follow-up from this study. The red curve there on the left is the treatment-naive patients. The blue curve is the relapse refractory. So as I mentioned, 31 patients that we treated, and you can see the median time on study when we reported this was a little over 5 years. The 5-year PFS was 92% in the treatment-naive patients, and the overall survival was similar. I have a couple of patients from this trial who've now been on continuous ibrutinib for almost 10 years, dating back to this original trial. So it's been a remarkable journey to see how well these patients have done. So that then led to the RESONATE study in relapse refractory patients, which enabled ibrutinib to gain initial approval. And then we went on to RESONATE 2. So this was a randomized phase 3 trial, frontline CLL patients 65 or older. So again, a focus on typical CLL patients in terms of age. It did exclude patients with deletion 17p, so we don't have data from this trial in that group, but it was very simple. It was a randomization between ibrutinib 420 milligrams once a day until progression, or what our FDA considered standard of care in the elderly at the time, which was single agent chlorambucil. Now, this study has been criticized because of the comparison to chlorambucil, but my view was, I don't really care. If a drug couldn't beat chlorambucil, you might as well pack it in and go home. But the real value of this trial to me is to know, how do patients do if they get ibrutinib in the frontline setting? How do they do over time? Of course, that's what your patient wants to know. They want to know, how long is this going to last? Am I going to develop resistance? And so that's the real value of this study. So at EHA last year, we presented a 5-year follow-up of this trial. And at 5 years, 70% of ibrutinib-treated patients versus only 12% of chlorambucil-treated patients were estimated to be free of progression and still alive. And of course, the study also showed an overall survival improvement of 83% versus 68% at 5 years. So as I mentioned, no big surprise to see this dramatic difference between the two. But again, one of the values here is to see what the natural history of the disease is as patients continue on ibrutinib. Now, when one looks at the subgroups, and we had traditionally thought of deletion 11q as an unfavorable group, You can see here the two top curves are the ibrutinib treated curves. Without deletion 11q is the purple, and the yellow is with deletion 11q, and they're really the same. So that was not a predictive factor with respect to ibrutinib. And similarly, and in contrast to what I showed you with FCR, the two top curves there are the ibrutinib treated patients mutated versus unmutated. Absolutely no difference. So here we're seeing equivalent efficacy in the unmutated group as well. Now, with up to 5.5 years of follow-up, you can see that over half the patients remain on long-term ibrutinib. So 58% of them were continuing on study. And you can see at the bottom the reasons for discontinuation, primarily an adverse event. But of note, only 6%, 8 patients, stopped ibrutinib due to progressive disease, right? So in other words, you want to know, if I'm taking this drug, how long is it going to work? So that's really asking, am I going to develop resistance? Am I going to progress on the disease, on the drug? And in our early studies, Resonate, and in the very first study I showed you in the heavily pretreated relapse refractory population, of course, you see a higher rate of progression. But in the frontline setting, only 6% of patients. So when you hear data from studies and you talk about progression-free survival with ibrutinib, remember the vast majority of progression is actually patients who have stopped treatment for some time, for some reason, and then of course, eventually their disease will progress. That's not the same as the drug becoming ineffective. So I think this is a very powerful data showing that if patients remain on therapy, their chance of actually progressing remains quite low. Now, another phase 3 randomized study, this was the ECOG 1912 study, and this was ibrutinib, in this case combined with rituximab, versus FCR. So we said we're going to compare it to our gold standard chemoimmunotherapy, FCR. Patients 70 and below, FCR versus IR. Primary outcome, progression-free survival. And again, this trial in the younger patients did not involve deletion 17p patients. So here's a summary of the results with a median follow-up of 4 years. You can see a 3-year progression-free survival superior, 89% versus 71%. You can also see that the 3-year PFS was higher in the IR group versus FCR for the mutated patients with a hazard ratio of 0.42, although that did not reach statistical significance. It was not, the study wasn't powered actually to look at the subgroups, but still a hazard ratio of 0.42 is something to take note of. Of course, in the unmutated patients, there was a dramatic difference that was statistically significant in favor of the ibrutinib arm. And then finally, and I think surprisingly to many of us at this early time point, there was an overall survival difference that was statistically significant in favor of the ibrutinib rituximab arm. So, and that survival difference was not because of increased toxicity with FCR. It was due to more patients dying from CLL if they received FCR as their frontline therapy. On the right there, you can see the PFS curves and also the similar curve for the IGHV unmutated subgroup. So 4 years median follow-up, and of course we'll be reporting longer term follow-up on this study as we continue. Here's the forest plot. just orient yourself to the vertical line. Everything to the left favors IR. Everything to the right favors chemoimmunotherapy. And the size of the boxes, of course, correlates to the size of the numbers of patients. If you go to the very bottom, the IGH mutation, yes and no, you can see small numbers of the mutated patients there. The confidence intervals do cross that vertical line, so it didn't reach statistical significance, but again, has a ratio of 0.44. So whether it's clinical features, or stage, or even cytogenetic abnormalities such as 11q, all were in favor of the ibrutinib arm. Now, why did patients stop treatment on this trial? So of the 350 who started the ibrutinib treatment, there were only 7%, again, very similar to RESONATE-2, 7% who stopped due to progression or death. 14% stopped due to an adverse event, and 7% for other reasons, the usual variety of reasons you see in clinical trials. So that gives us 95 patients. Okay, and so of those 95 patients who if we subtract out those who progressed on treatment, and we looked at the 72 who stopped for other reasons, so in other words, they hadn't become resistant, but they stopped treatment, they had been on treatment for a median of a little over a year, 15 months. And it wasn't until almost 2 years later, a median of 22 months, that progression was noted. And this is not even necessarily progression to requiring treatment again. So time to treatment would be even longer than this. But for a regimen that we've typically used continuously, we have some interesting data here that a little over a year of therapy and stopping led to a benefit that lasted almost 2 years. So very interesting, and we'll see how, again, what we see with these patients as we follow them a longer term. The companion study was the Alliance study, and this was in the older patient population. So these were patients 65 and above, and here we randomized to ibrutinib or IR or bendamustine and rituximab. Again, a very popular regimen in this patient population in the US. We know from the German experience, of course, that FCR is superior to BR in terms of progression-free survival, but the bendamustine and rituximab tends to be better tolerated. So it really was widely used in the US for the older population. Now, this trial did include some patients with deletion 17p, so we have data here. And here's the summary. Both the IR and the ibrutinib arms were superior in terms of PFS, not yet OS, with a median follow-up of about 3 years. And there's absolutely no difference by adding rituximab to the ibrutinib arm. So here we have a direct comparison of adding an anti-CD20 antibody to ibrutinib, and it didn't seem to add value. The hematologic AEs, of course, were higher in the BR arm, the chemoimmunotherapy arm, more myelosuppression. The non-hematologic AEs were actually slightly higher in the ibrutinib-containing regimens. But of course, keep in mind that with ibrutinib, it's a continuous therapy. With BR, it's finished after 6 months, so you do have more exposure to the drug. So that's kind of the top line summary of ibrutinib in the frontline setting. So 2 important things to emphasize. One is its continued efficacy as we follow patients. So we have long-term data on that, a very low 6-7% rate of true resistance to the drug. and also long-term safety. So we have tremendous long-term safety data with ibrutinib. In terms of side effects, the ones that you're, I'm sure, familiar with, when patients start therapy, sometimes we see diarrhea or rash. That tends to be very short-lived and resolves. We do get patients with arthralgias, of course, and again, that tends to be temporary, but some patients, it does continue. We've learned a bit more about perhaps how to manage that. We're a lot more comfortable with dose reducing to 280 milligrams in some patients if they've been on treatment for a while and have had a good response, and that often works for the arthralgias. We can see some easy bruising due to its effect on platelet function. And then finally, the two adverse events we do mention is atrial fibrillation and hypertension. So as patients have stayed on the drug longer term, that hypertension is something we do observe. Both of these cardiovascular events probably in the range of about 10% in the real world over time. But fortunately, in terms of AFib, for example, it often does not preclude continuing treatment if we feel a patient will benefit from it. These may be brief episodes, in some cases asymptomatic, but in many patients we're able to perhaps interrupt dosing, manage the AFib, especially if it's a transient event, and then restart therapy if we think it's appropriate for the patient. And of course, in the early days of the clinical trials, patients were very motivated to stay on therapy, so we learned a lot about managing these events, or even as patients stayed on therapy. And secondly, the high blood pressure. As I mentioned, we do see that in some patients, either new onset or worsening of pre-existing hypertension. So it's just something that you need to be aware of as patients stay on therapy. So our second generation drug, acalabrutinib, of course, went through typical early phase trials, and then there was this randomized phase 3 trial, previously untreated patients. The Elevate trial, acalabrutinib plus obinutuzumab, compared to what at this later time was standard of care now, not single agent chlorambucil, but chlorambucil plus obinutuzumab. Here's the top line results. PFS superior for the acalabrutinib arms. No difference between acala-obina versus acala alone. The study wasn't powered to compare those two arms. Here's the safety events, and a pattern that's very similar to what we saw with acalabrutinib compared to chemoimmunotherapy, with less of the hematologic toxicity. But at least at this early time point, there seemed to be less of a signal of the cardiovascular side effects, AFib and hypertension. But of course, we need longer follow-up. We need to see larger numbers of patients treated with this drug before we really have a comfort level regarding those particular side effects. I think many of the others, such as bruising or even the arthralgias, are similar between the two drugs. And then finally, what about combination regimens? And we have venetoclax. This is where venetoclax comes in. So venetoclax plus obinutuzumab in previously untreated CLL, the German CLL-14 trial. And this was also VO versus chlorambucil obinutuzumab. Here, the venetoclax was given for only 1 year. So time-limited therapy. Here's the PFS curves with a median of a little over 3 years follow-up. Highly superior with the VO combination compared to chlorambucil obinutuzumab. Again, not surprising to see this result. When one looks at IGHV mutation status, you again see benefit regardless of the mutation status, with the venetoclax arms. Those are the two top arms, but not so much of a distinction actually between chlorambucil, obinutuzumab, and venetoclax and obinutuzumab for the mutated patients. Those are the patients who do particularly well. But on the right, you notice there, the vertical line is 12 months. That's when you stop therapy. And the bottom curve there is, well, the bottom two curves really are the TP53 deleted or mutated patients. So what we're starting to observe is that if you have this abnormality and you stop therapy after a year, you're more likely to progress sooner. So our current feeling is that for those unusual patients with deletion 17p with frontline therapy, this may not be the best regimen for them. We prefer to use ibrutinib as upfront therapy. MRD was measured in this study, and and high rates of MRD negativity were observed in the peripheral blood, 3/4 of the patients with the VO regimen, in the bone marrow, not quite 60% of the patients. So highly active regimen in terms of MRD negativity. And of course, that's what allows you to consider a time-limited therapy, because you achieve a deep result. And not surprisingly, that translated to a longer PFS. So those who were undetectable MRD, the venetoclax obinutuzumab arm is the top line here in the graph. And interestingly, the chlorambucil obinutuzumab undetectable MRD, which is less common and driven entirely by obinutuzumab, also is favorable compared to those who are still MRD detectable. So the point is that the majority of patients with the VO regimen do achieve MRD undetectable, and that will translate to a longer PFS. This is a myelosuppressive regimen, certainly much more than the BTK inhibitors. You do see neutropenia, but fortunately, febrile neutropenia was quite uncommon. So it does require more management. It does require infusional therapy as opposed to our oral BTK inhibitors. Now, what we're going to be interested in, of course, is how well do patients do after they stop therapy? In other words, what's the benefit from a year's worth of therapy? That's really the big question that we're waiting to see the results of as these patients are followed further. And finally, I think the future, perhaps venetoclax plus ibrutinib. So we have some data here. This is from the MD Anderson. Nitin Jain has presented this data, and just as an example, these are the MRD undetectable rates in the bone marrow over time at 12 months. Again, 2/3 of patients, and perhaps a higher percentage as one continued on with this combination regimen for 2 years. So a very active combination of therapy, and again, an all oral regimen here. Here's the PFS and overall survival from the study. So there are ongoing trials. There's the Captivate trial that looks at this combination primarily to study MRD rates. And then there's the GLOW trial, which is this combination compared to chlorambucil obinutuzumab, which is meant to be a registration trial. So going back to our patient, what should the treatment goal be for this patient? Well, he's young. We need to see if we can keep him alive for another 30 years. So we need to use a regimen where efficacy is of paramount importance. We have single agent ibrutinib, which has the longest experience, a well-known safety profile. Acalabrutinib, a little less known about it long-term, and then the VO regimen. So I don't know if there's an ideal treatment regimen for him in particular. Remember, he's 13q mutated, so he's likely going to do well with all of our approaches. If he was unmutated, I think it'll be interesting to follow the VO regimen to see if there's a difference in long-term benefit after stopping therapy between mutated and unmutated. That's an unresolved question. And of course, as I mentioned, if he had happened to be the deletion 17p, we would advocate ibrutinib therapy. So here's the current NCCN guidelines in terms of obtaining prognostic information. I think we're probably going to drop the CD38, ZAP70, et cetera, and simply focus on IGHV and a TP53 determination at time of treatment. And finally, the current recommended regimens, and you can see whether you're frail, we didn't really talk about that, or young and fit. So for any CLL patient as frontline therapy, ibrutinib monotherapy is a preferred regimen with a category 1 recommendation. So the future, I think, is somewhat personalized therapy depending on the goals for that individual. Are they 80? You just want to shrink some bulky adenopathy, or are they young like our patient? Continuous oral monotherapy versus time-limited combinations. And as I mentioned and kind of alluded to at the end, I think the IGHV and FISH determination may differentiate therapies, even our novel therapies for some patients, which ones or which combinations we choose. BTK for deletion 17p, perhaps unmutated would benefit more from continuous therapy, but we will see. So I'll end there, and thanks again for inviting me to the conference.
Thank you very much, Professor Stevens, for this most illustrated and up-to-date discussion. And I have some questions.
Absolutely.
Thank you. Number one, in your first slide, you mentioned that the availability of investigation and drugs determine the outcome. I would just to enlighten everyone that IGHV testing is now available in Egypt, and the good news is that it is fully sponsored by Janssen, so it will not cause any burden to the patient. So it is available, as well as all the deletion studies and the genetic studies. The drugs that you have mentioned, acalabrutinib, venetoclax, and obinutuzumab, are also available in Egypt, as well as the old-fashioned bendamustine. So the decision is now for CLL patient is quite plenty. Okay? So just to make it clear, we have the option, or what's called the luxury, of doing whatever we want to the patient.
So that's a very important point. So that's good that you know what your options are, and that makes it even more important to, I think, really personalize the approach for your patients.
Particularly, we have a cluster. In fact, lots of patients, CLL patients, their age range, and I think Professor Ashraf will approve me, in the 30 and 40. So we have a younger age group, particularly for CLL and CML patients, not the 70 or 80s. Maybe 40 or 50% are above the age of 70, but we have a large group of patients who are younger than that compared to the Western population or the demography that is reported by the United States or the European nation. Okay? So that's why we advise for the chemo-free regimen for most of our young patients, particularly females who are going for delivery or pregnancy or whatever.
Yeah, I think we still see, you still see for the young fit patients who are mutated, right? Yeah. And then that's where that discussion comes in about FCR. And, many of my colleagues emphasize that. And of course, you do have that discussion, but, not everyone is cured with that regimen. There's one subgroup, it's an unusual one, mutated, trisomy 12. Most of those patients are unmutated. So I had a patient who was very savvy, and he chose FCR because he was trisomy 12 mutated. And he did great, MRD negative response. And 3 years later, about 4 months ago, he showed up with secondary AML. So, a real unfortunate situation, an outcome I'm sure he would not have had if he hadn't been exposed to the chemotherapy. So there can be consequences, and not everyone gets that benefit. And for that reason, I believe even for those young mutated patients, I don't really think there's a role for chemotherapy.
Yeah. My point, this is a question for you, sir. Particularly in the ALIAS study, they used the ZAP17 methylation more or less than 20%, and the NCC guideline used it. Don't you think that the ZAP17 have some concerns, or it's not as promising as it used to be, or considered not that much as a decisive point?
I agree. We don't obtain it. We never have, for years now. It really came up because determining the IGHV mutation status was not readily available. It was really in a research lab. And so this was sort of a surrogate, if you will. There's not a direct correlation, but it is true that most who are ZAP70 expressing are the unmutated patients, although it's not 100%, as I mentioned. So I would really discourage getting that result. I don't think I think you really should focus on the mutation status, especially since it's available to you now. So it wouldn't surprise me if we drop ZAP70, CD38, all of those from the NCCN guidelines in terms of prognostic markers.
Perfect. We're going to start our was prepared question, and the first question will go for Professor Stephen. What is the cutoff point for determining 17p deletion? The cutoff point.
Well, the cutoff point. Well, there's data that's been generated with chemoimmunotherapy showing that, for example, one large study, a cutoff point of 20% was meaningful. But I would say in terms of the novel agents, all the studies that have been done, there is no cutoff point. You're positive or you're not. And I think, most of the FISH assays probably have a sensitivity down to maybe, 2% or so. So if it's detectable, it's detectable by FISH. So whether it's 5% or it's 30%, at least from what we know currently, it's the same. It carries the same prognostic information.
Yeah. Second question, sir. Can you measure the MRD negativity for the patient by measuring the reduction in the percentage of mutation or 17p deletion? I mean, can you...
No, those are not. Remember, the mutation status is inherent to that patient's CLL. It's either mutated or unmutated. So it's if you will, it's a qualitative measure, right? I mean, of course, you can be 12% mutated or 4% mutated. Anything more than 2% versus the somatic sequence is considered mutated, but that's not quantitating how much CLL there is. And then in terms of, let's say, deletion 17p, no, those are not, whether you do that by an NGS methodology or you do it by FISH, those are not MRD tests at all. I would not view them that way. You really have to do either a validated MRD flow assay, or we're exploring in clinical trials NGS methodologies that might be sensitive down to 10 to the -5th or 10 to the -6th even.
The next question will be directed to both Alexandria University, Ashraf, and Stanford. So, Professor Stephen, in your practice, do you consider, in the current days of the what's called the COVID era or the Corona era, you will advise for the anti-CD20 BCL2 immunosuppressive regimen reduction for CLL patient or no?
Yeah, that's a very good question. I think it depends on your particular circumstances. We've had these discussions. My colleague Rick Furman in New York City, they were very heavily impacted, as you know, by this, and they really weren't doing infusional therapy. So any of the anti-CD20 antibodies were out. Of course, they tried to delay therapy in patients if they could, but some patients they couldn't, and so much easier to start a patient like that on single agent ibrutinib. And yes, the anti-CD20 antibodies, the VO combination is more immunosuppressive because of the antibody. So I think that does play into your decision if you're in an area where COVID is currently quite active.
Will you go for antiviral prophylaxis for those patients or no?
Personally, no. I don't routinely use antiviral prophylaxis in the trials. Sometimes we're required to, but if somebody has a history of recurrent cold sores, for example, HSV, then prophylactic acyclovir is very reasonable. I will mention, just as an aside, and you may have seen this, is some anecdotal data that BTK inhibition may be beneficial in COVID infection. So my colleague Steve Treon's observation in 4 of his patients with Waldenstrom's, and then a prospective study that was published in Science Immunology looked at 18 patients. In this case, they used acalabrutinib, and these drugs we know inhibit the inflammatory cytokines. They inhibit macrophage activation, and it appears that at least in some patients with COVID that macrophage activation, for example, is important in the pulmonary injury that you see. So in that one study, there seemed to be a decrease in the days on a ventilator in some patients, or days requiring oxygen therapy. Somewhat similar to what was demonstrated with remdesivir, the antiviral. So we're currently doing a randomized clinical trial, a double-blinded, placebo-controlled trial for patients with COVID infection, not with cancer, who require oxygen therapy to see if it improves outcomes. So that'll be very exciting. I think by the fall we'll have an answer to that.
Okay, Professor Ashraf, in your practice, do you find that the CLL patient will need modification for their anti-CD20 therapy or things like that in the COVID area, and how you manage those patients?
I think I have commented this point. They're very important. If your patient is on anti-CD20 or whatever monoclonal antibodies, and you are going to shift it to oral as ibrutinib or acala, whatever, it's possible to give him back the monoclonal antibodies after a few months of that COVID or not. This is the question. Actually, I don't do that. I insist to maintain the patient on his treatment, actual treatment, whatever it's oral or monoclonal, unless there is a contraindication for immune suppression or whatever. But the question here for Professor Steve, it's possible to shift from IV oral and then again back to its IV, or what? In your opinion?
Well, I mean, I think that really depends on an individual patient. Why did you choose to use the anti-CD20 combination? What are you trying to achieve in that patient? Interestingly, there's many people who feel that we give obinutuzumab the wrong way, that we shouldn't actually use it initially as part of a combination. Instead, it should come later. The real benefit would be later, if even combining it with, say, venetoclax, not necessarily giving it the first 6 months, but perhaps giving it later in the course. But I think it all depends. I think if you're using, obviously, if you're using a BTK inhibitor, we don't advocate anti-CD20 antibody as well. And if the whole point of the VO regimen is to get a deep response so you can stop therapy. So I guess if you had to interrupt the obinutuzumab, you continue the venetoclax, and then you depending on when you can restart the infusion, if it's 4 months later or 6 months later, I mean, maybe you should just continue single agent venetoclax for a time. But that requires measuring MRD, and I think I think if you have to abandon giving obinutuzumab early in a course of VO, then perhaps you're better off just switching the patient to a BTK inhibitor at that point. It's hard to say. I think it's an individual decision.
Okay, that's good.
Thank you. Professor Stephen, there was in the recent years, there's been a debate about the principle of sequencing treatment. Do you consider sequencing treatment in relapsed CLL is an option, or does it have any value?
Yeah. So, people talk about sequencing and they say, well, I want to save the better drugs for later. Hopefully we've gotten beyond that concept. Certainly I think there's a presentation for frontline therapy of myeloma coming up. And, that's something we used to debate endlessly in myeloma. And we've gotten beyond that. We got to give you best therapies initially. But the other way of looking at sequencing, of course, is, well, what happens if you progress on one of these drugs? Are you going to respond to another? And we are starting to get data with that. Certainly, we've done trials specifically with venetoclax for those who progressed on ibrutinib or became resistant to it. We know the drug works. From the Murano trial, where venetoclax was used in the relapse setting only for 2 years. Of course, some people progress after stopping therapy, and there's data on the use of ibrutinib in that setting. It seems to work fine. There's even some data with venetoclax, retreatment with venetoclax. So I think, I'm confident personally, just from my personal experience, that we can use the drugs again, and we can sequence them in either direction. But of course, with more time, we'll gather more data to really justify that approach.
Perfect. For both experts, this is the next question. What is the goal of treatment from your point of view? What is the goal of treatment for CLL in general? And in which population is it appropriate to use frontline therapy, the newer medication? So what is your goal of treatment, number one? And number two, this is in general. Number two, which population you see it will fit them to use the appropriate drug at the first line, the expensive drugs, I mean?
Well, I think, as I mentioned, I think the novel agents are appropriate for everyone. I think that, at least for the average patient in the U.S., patient who's 70 at diagnosis, who doesn't need treatment until they're in their mid-70s, I think putting them on oral ibrutinib will allow them to live for the rest of their natural life. I think that's, if you will, a functional cure. They won't die of their CLL. Of course, it's the patient that I presented, the 55-year-old, whose horizon is not the next 10 years, it's the next 30 years. They want to be alive for the next 30 years. And of course, we don't have that experience. But I think the novel agents are the best therapy for that patient, not chemoimmunotherapy. And our goal in that patient, again, is going to be get the best disease control for the longest time. It sounds trivial, but that is the goal. That, again, is in contrast to perhaps that 78-year-old who the reason you're treating is because there's unsightly and symptomatic bulky cervical adenopathy. Hey, do I want to treat that patient to MRD negativity? Not necessarily. I want to shrink their lymph nodes so their quality of life is good. And again, I think the novel drugs work very, very well in that situation. So we have a scenario, ironically, where these drugs work for the elderly, they work for the frail, and they also work very well for the young, fit patients and are appropriate for those patients.
Professor Ashraf?
Aywa?
What is your main goal of treatment in CLL? And do you consider special population that needs the expensive drugs that are not fully subsidized in Egypt? So your goal of treatment?
Do you think that CLL is curable disease? First of all, this is my question. It's not.
If a patient survives 90 plus, it's a curable disease. Yeah.
So I think it's for controlling these symptoms and burden disease burden. To get MRD, I think it's not now. It may takes a lot of years to control it. It's not. It's controlling for symptoms and burden disease. That's my goal, actually. I think
I agree. I mean, I agree. That's fundamentally what you're doing. I don't think we're at the point of our goal is to treat the MRD negativity in all patients. I mean, that may be an appropriate goal for a young patient to get the longest duration of response that we can. But of course, that's not relevant with single agent ibrutinib. That's not how it gets its long-term benefit, by driving to MRD negativity. It's by staying on a continuous therapy that controls disease and symptoms, like you say. And that's a good goal for treating a patient.
So I'm going to ask the question in a different way. Based on each one of you, your experience, I'm going to give you 4 parameters. You have to classify them from 1 to 4 according to the importance. Age, comorbidity, deletion 17, IgHV mutation. Classify according to importance. Your decision. Age, comorbidity, deletion 17, IgHV. Don't laugh, Asfer.
The younger is very important.
Which is more important for your decision?
But regarding deletion 17, I think it's when decision to treat.
So number 1, deletion 17.
When to decide to treat.
No. Just classify them as they are.
I think it's deletion 17, maybe. Second, it's comorbidities. Third, age. Lastly, IVHD.
Professor Stephen?
Yeah, I would say, deletion 17p, because even though the drugs work quite well, there may be a differentiation, like I mentioned, in choosing, say, a VO regimen versus an I regimen. So I want to know that. Then comorbidities, absolutely. And then, I don't know. It's a toss-up between age and IgVH. I think we'll see the Ig mutation status with longer follow-up. It'll be really interesting to see if there's a difference in the VO regimen. There isn't with ibrutinib long-term. Both work fine. So in that, with ibrutinib, then I'd put, say, age over mutation status. But
okay. And now, finally, what is the recommendation for using ibrutinib in patients with AF and or bleeding tendencies? Those who are having cardiac problem and bleeding tendency patient. Do you approve or recommend using ibrutinib, and how to tackle this problem if you're going to use ibrutinib? Professor Stephen?
Well, of course, we learned about this in the early days, because as I mentioned, when ibrutinib wasn't commercially available and was the only way to get it was on a trial, especially for the heavily pretreated patients, we did everything we could to keep them on the drug. So we dealt with that situation successfully in many cases. However, the world's different now. We have other options. We have a different class of drug. I mean, if somebody has well-controlled AF, for example, and is even on, direct-acting anticoagulant, not warfarin, not Coumadin, then I'm very comfortable treating them with ibrutinib, for example, if I think it's the best drug for them. Now, if their AFib is much more problematic, or in terms of bleeding, they have significant bleeding tendencies to begin with, then perhaps it's not the best drug to consider as initial therapy. And there I might choose a venetoclax-based regimen. So I think there's some nuance in a patient with AFib. I don't consider it a contraindication to the use of ibrutinib for all patients.
Yes. Professor Ashraf?
Yes. I think it's...
For AF patient. controlled, uncontrolled, will you go for ibrutinib?
Weighting risk benefit ratio.
Yeah, risk-benefit ratio, exactly.
Yes.
Well, thank you very much. Very, very, very informative presentation and very informative questions. And thank you again. Thank you very much.
Thank you. Thank you. It was a pleasure.
Pleasure myself.
Next time in person.
Hopefully. We should go to Alexandria, the perfect weather in the world, and the most generous people.
Thank you.
Thank you. Fadal ya fندم.
Hello again. Hello everybody. It's nice to see you again. First of all, I would like to thank Jansen for supporting this program, and I would like to thank Professor Manal for letting HemoAlex to be the main contributors. Okay, I would like to. It's nice for me to present Professor Dr. Manal, Professor of Hematology, and head of Bone Marrow Transplant Unit, Alexandria University. And she's actually is a dynamo for HemoAlex, as always. Okay, she's going to give us a brief presentation about optimizing frontline treatment of multiple. Thank you, Professor Manal.
Okay, thank you, Professor Ashraf, for the kind introduction. And as you said, my topic will be optimizing frontline treatment for multiple myeloma. Of course, we all know that multiple myeloma is a clonal plasma cell disorder which accounts for about 10% of hematological malignancies. The disease has an estimated incidence of about 5 per 100,000 population per year in Europe, and primarily affects elderly patients with a median age at diagnosis of 72 years. Actually, we all know as Egyptians that we see our patients at younger ages. We see many patients in their 40s and 50s, and even every now and then we may see a patient in his 30s. Over the last decade, the treatment landscape for multiple myeloma has evolved significantly, with a vast array of therapeutics being now available. And we all know that these include immunomodulatory drugs, proteasome inhibitors, and monoclonal antibodies. As a result, we face a situation in which we are not always able to decide which drugs to use and when, and whether these should be used in a particular sequence or in combination. So the decision here could be sometimes challenging. Clonal heterogeneity is often observed in patients with multiple myeloma, and it has been suggested that suboptimal treatment may lead to eradication of sensitive subclones while allowing resistant clones to expand. Consequently, this may be a rationale for combination therapy using agents from different drug classes with distinct and synergistic mechanisms of action in an attempt to reduce the risk of developing drug resistance and to induce deeper responses. Although combination regimens are associated with better long-term outcomes, we all know this, but some patients may not be able to tolerate the adverse events of these combinations together, and hence, in these particular patients, a sequential approach may sometimes be more appropriate. So just to remind you of the International Myeloma Working Group criteria for diagnosis of multiple myeloma, of course, we have to differentiate between MGUS and smoldering myeloma and active or symptomatic myeloma, which is the one indicated for treatment. Both MGUS and smoldering myeloma do not have myeloma-defining events, although they have the M protein, whether less than 3 grams or more than 3 grams. They could have the monoclonal protein in the urine. and clonal plasma cells up to 60%. But active myeloma, in addition to these features, has at least one or more slim crab features. The slim features, we all know also, is 60% or more clonal bone marrow plasma cells, serum free light chain ratio equal to or more than 100. If kappa is involved, if lambda is involved, then it is equal to or less than 0.01. MRI studies with more than one focal lesion, more than 5 millimeters in size, and the crab criteria with hypercalcemia more than 11 milligram, renal insufficiency, creatinine more than 2 milligram per deciliter, or creatinine clearance less than 40 milli per minute, anemia less than 10 gram hemoglobin, and bone disease with at least one or more lytic lesions on imaging. So to diagnose myeloma, we have to do bone marrow assessment. We have to assess the monoclonal M proteins, whether by electrophoresis or assess the free light chains in the blood to confirm activity of the disease. And we have to do whole body low-dose CT or MRI to detect the lytic or focal lesions. That CT is very useful in determining the treatment response or disease progression. In newly diagnosed multiple myeloma patients, start of therapy is immediately required if you have one or more myeloma-defining events, which we have already stated. And the first step before deciding or selecting the most appropriate therapy is to determine if this patient is transplant eligible or not, and this depends on the chronological age, performance status, and comorbidities. Of course, we transplant patients up to the age of 65, but if we have a patient who is more than 65 up to 70 years and he has a very good general condition, no significant comorbidities, and he is fit for transplant, then we go for it. In fit patients who can tolerate novel agent-based therapies at full doses, key treatment endpoints are to achieve complete responses with undetectable MRD. And I think this is somewhat a shift in the paradigm because several years ago, we were satisfied with very good partial responses. But now, because we know the impact of MRD negativity, we are aiming at complete responses and undetectable MRD. Not only to achieve undetectable MRD, but to sustain it, because this usually is translated into longer progression-free survival and overall survival. The increased availability of highly effective targeted agents with limited overlapping toxicities raises the potential for shifting the therapeutic paradigm towards the use of effective 3 or 4 drug combination strategies. Of course, we all know the POLLUX and the CASTOR trials both demonstrated that when you compared DARA-RD with RD alone, patients who achieved MRD negativity had better progression-free survival than patients who were still MRD positive after treatment. And also in the CASTOR trial, when DVD, DARA-VD was compared to VD alone, patients who were MRD negative had significantly better better progression-free survival than patients who were MRD positive in both arms. So, on the other hand, in frail patients who cannot tolerate treatment with multi-drug combinations, our goals of therapy may be a little different. So here we can aim at improving the quality of life and avoid early treatment discontinuation due to drug toxicities so that we can control the disease as much as we can. Just a reminder about the revised ISS staging system and the correlation with overall survival. Of course, the factors considered, we know, are the serum albumin, the beta-2 microglobulin, and the serum LDH, and of course, the high-risk cytogenetic profile, the translocation 414, translocation 1416, and deletion 17p are present in stage 3 ISS, which has an overall survival of 43 months as in opposition to patients who are revised ISS stage 1, the overall survival was not reached. So if we have decided after assessment of the patient that this patient is transplant ineligible, how do we consider treatment? Of course, we have to think if this patient is fit or frail and unfit, what is the comorbidity present if he has associated comorbidity, and then decide according to that. So if the patient is fit, we can use 3 drug regimens with available dose reductions to improve tolerability. And one of the examples for this is VRD light. And we can also use DARA-RD. In frail, unfit patients, consider starting with doublet therapies like lenalidomide dexamethasone or bortezomib dexamethasone, and adding a 3rd agent if this becomes tolerable after geriatric assessment. In patients with renal dysfunction and the patient will receive lenalidomide, then you have to dose adjust according to creatinine clearance. If the patient has cardiac dysfunction, avoid carfilzomib and use thromboprophylaxis with lenalidomide-based therapy. If the patient has peripheral neuropathy and you want to give him bortezomib, then the subcutaneous route is preferred, and you can use the once weekly dosing. Consider also you can give IRD, ixazomib, Revlimid, dexamethasone. So these are the results of VRD Light, which is a phase 2 trial in older transplant ineligible patients. Overall responses here were 86%, with at least 66% achieving at least very good partial response. The median progression-free survival was about 35 months, and overall survival was not reached. Also, the phase 3 SWOG, which tested the efficacy of VRD versus RD in newly diagnosed multiple myeloma without intent for immediate transplantation, we find that there was a survival advantage between in the VRD arm as regards the median progression-free survival and also the overall survival. When we compare the VRD to RD, the median progression-free survival for VRD was 43 months compared to 30 months in the RD arm, and the median overall survival was higher for VRD, 75 months compared to 64 months in the RD arm. The phase 3 MAIA trial, which tested the survival with DARA-RD versus RD in older or transplant-ineligible patients with newly diagnosed multiple myeloma. After 36 months of follow-up, the progression-free survival at 36 months was 68% for the DARA-RD compared to 46% for the RD alone. The median progression-free survival for the DARA-RD was not reached, while for the RD arm, it was 33.8 months. If we look at the MRD negativity, of course, the PFS was better in patients who were MRD negative in both arms, but MRD negativity was increased in the DARA arm, and about 1/3 of the patients became MRD negative compared to RD alone. 9% were MRD negative. So what are the currently available treatment options for newly diagnosed transplant-eligible myeloma? The commonly used induction regimens include VRD. We still prefer VRD. KRD also can be used, and we have promising data with DARA-VRD. Autologous transplant should be sought for or should be investigated as an option for all patients. And maintenance therapy with lenalidomide is preferred, although in some cases we may need, for instance, to use maintenance with a proteasome inhibitor in special categories of patients like high-risk patients or inclusion into a clinical trial. What about the endurance trial in which the PFS and OS with bortezomib plus RD was compared to carfilzomib RD? The median progression-free survival were comparable in both arms after a median follow-up of 15 months, and the overall survival was not reached after a median follow-up of 29 months. Also, the Griffin update, which compared DARA VRD to VRD alone, the progression-free survival and the overall survival were not reached in either study arm after a median follow-up of 22 months. Although after 24 months, the PFS rate, the curves were starting to separate for the DARA VRD arm. What about the benefit of transplantation in newly diagnosed multiple myeloma? Of course, in this trial, the phase 3 IFM, patients 65 years or younger with symptomatic newly diagnosed multiple myeloma were randomized to receive either 8 cycles of VRD or to receive 3 cycles of induction with VRD, and then milfalin 200 conditioning and autologous transplant, and then 2 cycles of VRD as consolidation. MRD would be assessed, and then maintenance for 12 months with lenalidomide, and then reassess MRD. The results of this study were in favor of transplant arm because the progression-free survival was definitely higher with VRD plus transplant, 50 months, versus VRD alone, 36 months, while the overall survival was comparable in both arms, about 81 months. This was the 4-year overall survival. The next trial was the comparison of the PFS and OS with lenalidomide maintenance after autologous transplantation in multiple myeloma. This was a meta-analysis of 3 phase 3 trials, and definitely the progression-free survival was very much increased in the lenalidomide arm. It was 52.8 months compared to 23.5 months for the observation arm, more than double the PFS. The overall survival at 7 years also, the curve started to separate in favor of the lenalidomide maintenance, which was 62% versus 50% for patients in the observation arm. So this stresses the importance of maintenance with lenalidomide post-transplant. What about the Cassiopath, which is a sub-study of the Cassiopeia phase 3 trial? Transplant-eligible patients with newly diagnosed multiple myeloma, ECOG PS 0 to 2. PET-CT was done at the start before induction, and then patients were randomized into 2 arms. The first arm received DARA VTD 28-day cycles for 4 cycles. The second arm received VTD alone for 4 cycles, and MRD was assessed post-transplant, consolidation with 2 cycles of either DARA VTD or VTD, and then MRD and PET-CT was done. Patients who achieved more than partial responses were randomized to either maintenance with DARA monotherapy for 2 years or until progression, or observation until progression. And as we see here, the PFS for the DARA-VTD arm was significantly higher than the VTD arm. It was 93% versus 85% at 18 months. And this means 53% reduction in the risk of progression or death in the DARA-VTD arm. If we look at the results of MRD negativity using flow cytometry at the level of 10 to the power of -5, DARA-VTD was superior across all subgroups of patients regarding sex, age, the ISS stage, cytogenetic profile, baseline creatinine or hepatic function, and type of myeloma. And as we said, this included the high-risk cytogenetics, and ISS stage 3 was in favor of the DARA-VTD, as the MRD negativity was about 64% versus 44% in the VTD alone. So the results of the Cassiopeia trial, which was conducted in transplant-eligible, newly diagnosed multiple myeloma, stated that DARA-VTD induction and consolidation improved both progression-free survival, overall survival, and not only that, but MRD negativity versus VTD alone. More patients who received DARA-VTD than those who received VTD alone achieved both PET-CT and MRD, what we call double negativity post-consolidation, and it was found that this double negativity correlated with progression-free survival. So treatment with DARA-VTD versus VTD alone was associated with more favorable progression-free survival, as the post-consolidation PET and MRD double negative versus non-double negative were higher in DARA-VTD arm. So these are the options for the first-line treatment. What do we do if the patient relapses after first-line treatment? How do we choose the second line? How do we choose the third line? Of course, if the patient progresses, you have to consider what he received during the first line of treatment and the pattern of response or resistance to these drugs. So you shouldn't repeat a drug that the patient showed refractoriness to, and the options are open. So, for instance, you can choose anti-CD38 monoclonal antibody with pomalidomide dex if the patient had lenalidomide in the first line. Daratumumab would be given with a proteasome inhibitor and dex. Bortezomib, pomalidomide, dexamethasone, carfilzomib, pomalidomide, dexamethasone, and so on. Also, the optimal third line therapy could be given if there is toxicity to the second line, or if there is resistance to the second line. Cyclophosphamide could be an option as a new drug that wasn't given before, pomalidomide if not given before, carfilzomib if not given before, proteasome inhibitor, and so on. Selinexor. What do we do if the patient is resistant to many lines of treatment, refractoriness to many lines of treatment? So selinexor is a selective inhibitor of nuclear export. It binds to exportin 1, which leads to blocking the transport of several proteins involved in cancer cell growth from the nucleus to the cytoplasm, and this ultimately leads to apoptosis of the cell. This drug is indicated in combination with dexamethasone for adults with relapsed refractory multiple myeloma who have received at least 4 prior therapies. These are very resistant, very refractory patients, and whose disease is refractory to at least 2 proteasome inhibitors, at least 2 IMiDs, and an anti-CD38 monoclonal antibody. This is an oral drug. The dose is 80 milligram orally plus dexamethasone 20 milligram on days 1 and 3 of each week until disease progression or unacceptable toxicity. So just a hint about some tips in the treatment of relapsed refractory myeloma. Carfilzomib resistance. If the patient is resistant to carfilzomib, then most probably he will be resistant to bortezomib or ixazomib. If the patient you started with pomalidomide and he is pomalidomide resistant, then most probably he will be lenalidomide resistant. So this just highlights that we should start with the less powerful, the less potent, and then the more potent, not the other way around. Whether daratumumab resistance is equivalent to isatuximab resistance is still not known. Isatuximab is another anti-CD38 antibody, and trials are still needed to elucidate the if it is equivalent to daratumumab resistant or not. And for heavily pre-treated patients, treatment options, as we said, include selinexor-based therapy, also clinical trials with various BCMA-targeted agents like CAR T cells and bispecific agents, venetoclax if the patient is translocation 1114 positive, novel alkylating agents, and novel cereblon E3 ligase modulator like iberdomide. Thank you for following.
Thank you, Professor Dr. Manal, for your such elegant and you give us back the feeling of multiple myeloma again and again, having been seeing that. I think it's better to take chance for the presence of Dr. Azazi, and I have many questions for both Dr. Azazi and Dr. Manal. The first of all, it's for transplant in eligible patients. What can be the consideration taken to ensure depth of response since these patients are deprived from transplantation? I think it's Dr. Manal. Can you answer this question, please?
Yes, of course. To aim at MRD would be the logical answer, and you can give something like daratumumab with VRD or something like that.
It's non-transplant. Okay.
Yes, you said transplant ineligible, right?
Yeah. Okay. Dr. Azazi.
Well, yes, like Professor Manal mentioned, we'll go for the same strategy, the deepest response possible, the longest response possible, and maintenance therapy, it has to be done. And like Professor Manal mentioned, I may use 2 drugs for maintenance for those patients. So the deepest response and the longest response will at least maintain this patient surviving quite well, hopefully.
Okay, I have another question for both of you. As a transplanter, I'm not a transplanter actually. When do you consider consideration cycles post-transplantation for your patients?
Yes, usually in the high-risk cytogenetic group, for instance, or if the patient had, usually we transplant upfront, you know, but if the patient had relapsed before, something like that, he's a high-risk patient.
Agreed. So, high-risk patient, definitely high-risk patient. Yeah.
High-risk patient. So you should give consolidation cycles post-transplantation.
Yeah.
This question actually, it's I need from your answer. It's regarding the COVID pandemic. What extra precautions do you take with your patients? Do you give any prophylaxis treatment?
Prophylactic treatment meaning antiviral? No, but you can as mentioned before, for CLL also, you can communicate with the patients through telemedicine, for instance, through video conferences and so on, instead of the direct contact. You can try to maintain the patients on oral drugs instead of parenteral drugs. Or if you can give something that can be given orally, like lenalidomide, Dexa, or ixazomib, or something like that, it could be an option here to avoid also going to the hospital and receiving injections. You can try, of course, a therapy that is not necessary, you try to avoid, like, for instance, the bone modifying agents or something like that. You can try to avoid this. This can be postponed till afterwards, after the problem that we have with COVID. You can maybe you can, if the patient is taking something that is taking a medication or is taking induction or something that can cause neutropenia, you may sometimes resort to giving colony stimulating factors like GCSF to diminish the period of neutropenia. I think the logic approach is to try to decrease. You can also sometimes decrease the dosing of the drug, the frequency of the dosing. Like, for instance, if you are giving Velcade, you give it once weekly instead of twice weekly. If DARA, you can lessen the frequency of giving the infusions, and so on.
Dr. Azazi, do you give prophylaxis?
Yes, we'll go for prophylaxis, definitely, yes. Antiviral, antibacterial, yes. First, like Professor just mentioned, limit the visit to the hospital. Do your very best that this patient will take his treatment at home. The subcut therapy would be ideal for those patients. You might even send nurses there if needed. It's very important that those patients will go for elective isolation, not social distancing, just elective isolation. We definitely will postpone the auto-transplantation as much as we can for those patients. And if we have to do it, then we advise the policy like the EPMT recommendation, 3 negative PCR COVID test for both the patient and or those who are going to accompany the patient during the isolation period. And if the patient needs, for example, allo transplantation or whatever, both the donor and the patient must have 3 negative PCR testing. Okay, but definitely we'll do our very best to postpone the patient, maintain him or her on prophylactic antiviral, and hope for the best.
Okay.
Can I come in here? Because transplantation, I think we are transplanting the myeloma patients without many problems, but we are taking precautions with the nursing staff, because we have problems that some of the nursing staff are working in other as private nurses in other hospitals or something like that. So we take strict precautions who comes into contact with the patient. But we have had no problems with autologous transplantation.
We shut down twice. We shut down our facility twice.
Yes.
For the sake of those nurses who turned out to be positive for COVID. Yes. So this is a major problem.
Yes.
And very expensive to maintain the practice with frequent testing and things like that.
Okay, I have here a question. I think it's a situation some of us face it or is going to face it. If you have a patient who's COVID positive during treatment, we stop immediately, but when do you intend to return him back on treatment? I think we face it, and I'm going to face it in the future.
Dr. Azazi, I think, answered at least. He said 3 tests, but usually it's advised to be at least 2 tests are negative. But Dr. Azazi enforced the precautions more and said 3 tests are negative.
3 tests, do you do it to ensure it?
100. It has to be 3, Ashraf, because some of those patients may recover late, and some of them may not even develop the tests. They will continue to be negative for a very long period of time, up to 3 months. So insist on the 3 tests until you are fully reliable. Now, let me remind you again that COVID is not just a once in a life disease, as we used to say. No, some patients relapse after 3 months, particularly the hematologic patient. They tend to relapse, and some of them had a second infection with a different strain. So it's very tricky, and we have to do lots of precaution. Number 1, early use of dexamethasone in those patients is a must. Sometimes you may resort to Actemra because it tackles the interleukin-6 receptor, which has double benefit in myeloma patient. So it's a treatment for the COVID patient because this is the only option to stop the cytokine storm. And this is a rheumatoid, the drug that is used by Roche in rheumatoid disease. The Actemra is the only option for those patients, plus high-dose dexamethasone. Otherwise, the outcome of those patients tends to be not good at all. And the use of antiviral if possible.
I confirm that it's very important issue here. Multiple myeloma, it's not a rapidly progressive disease unless it's in few instances. So we can wait to get negative patient and to be stabilized.
Actually, Ashraf, rescheduling policy for myeloma patient and CLL patient is very beneficial. Of course, the AML, we cannot postpone it much, but the high-risk myeloma patient, the outcome is not, as Professor Manal mentioned, the high-risk patient need to go for transplantation without delay.
Okay. My last question is for both of you, and I think it's an important question here. It's mention daratumumab in front setting in transplantation. Is there a specific patient profile that you recommend to start daratumumab with for both of our?
I think its main benefit is to deepen the MRD, to control. Maybe also it could be beneficial in high-risk patients. High-risk cytogenetics, something.
Yeah. Well, Ashraf,
what your profile, patient profile? As you mentioned, it's high-risk patients.
High-risk cytogenetics, for instance, he is already receiving VRD. Maybe if I add DARA to VRD, for instance, could be of benefit in increasing the responses and diminishing the burden of the myeloma in these patients, so that he can go to transplant.
Dr. Azazi, what's your opinion?
It depends on the subsidization states. If the patient is, for example, insured or have some sort of subsidization, yes, I will go for DARA as early as possible, particularly for the young patient or those patients who failed to respond to previous line of treatment. So for a young patient, definitely I will go for DARA to deepen the response as much as I can, okay? And to give the patient the maximum benefit after that. Even there are consideration now, or some trials considering maintenance therapy with DARA. So yes, I will go for that. Whether the patient afford or not, yes, I can go with that, particularly for the young.
Okay. I think that's all our question. First of all, I would like to thank Professor Dr. Mohammed Azazi, and hope to see you soon in Alexandria. I think it's
yes,
a wish. I would like to thank Professor Manal Soradi. She's General Secretary of X. She's doing a wonderful meetings. Okay. Hope to see you again. And goodbye all. Thank you very much. Thank you very much.
Thank you very much.
Bye.
Have a nice day, Ashraf. Salam.
Assalamu alaikum.